Welcome to the deep dive. Today, we're tackling a really critical part of the body's stress command center, the adrenal glands. You can think of them as these, well, tiny powerhouses, almost like little crowns sitting right on top of your kidneys. They might be small, but they're orchestrating this huge symphony of vital hormones. So, our mission today, we're going to unpack the amazing complexity of these glands. We'll look at the hormones they make, how everything's regulated, which is just astonishingly precise, and importantly, what happens when that regulation goes wrong. We're aiming to pull out the key insights from, standard medical physiology sources and really make it stick for you, especially if you're navigating your first year of medical school. We want you to get the why.
Absolutely. And understanding that why is, well, it's foundational as you move towards clinical practice. The key insight right from the start is recognizing that the adrenal glands aren't just one thing. They have this dual nature. You've got the outer cortex and the inner medulla. Completely different origins embryologically and totally different functions. Grasping that difference early on, it helps you understand why, say, metabolic symptoms linked to the cortex arise from different triggers than the super fast fight or flight stuff from the medulla.
Okay, right. Two factories in one tiny package. Let's start with the basics then, the anatomy. Where exactly are they?
Well, the name gives it away. Adrenal literally means above the kidney. So yeah, they sit like little hats, as you said, one on top of each kidney. And they're incredibly well supplied with blood, lots of arteries feeding in, but interestingly, just one main vein draining each gland. The right one goes straight into the big inferior vena cava, while the left drains into the left renal vein first. Something to keep in mind for surgery, perhaps.
Good point. Okay, so we have this outer part. The cortex looks more glandular, right? And then the inner part, the medulla, which you said is almost more like nerve tissue.
Exactly. The cortex is the bigger outer layer, and it's where the steroid hormones are made.
Steroid hormones. Got it. Can you break down what the cortex produces? I hear there's a mnemonic for this.
Yes, the classic mnemonic. It really helps keep the three cortical zones straight. As you go from the outside in, remember, salt, sugar, sex. So the outermost zone is the zona glomerulosa. Think G for globules, maybe. It makes mineralocorticoids, primarily aldosterone. That's your salt. It manages sodium and potassium balance.
Salt, glomerulosa, aldosterone.
Okay. Then the middle zone, the thickest one, is the zona fasciculata. F for fascicles or bundles of cells. This is the sugar zone, producing glucocorticoids, mainly cortisol, which is crucial for metabolism, especially glucose regulation.
Sugar, fasciculata, cortisol.
Okay. And finally, the deepest layer, right next to the medulla, is the zona reticularis. R for reticular, or network-like. This is the sex zone, producing weak sex steroids like DHEA.
Salt, sugar, sex, glomerulosa, fasciculata, reticularis. That's actually super helpful.
It is. And one more crucial thing about all these cortical hormones, there's steroid hormones derived from cholesterol. That means they're lipophilic, fat-loving.
Ah, so they can slip right through cell membranes easily.
Precisely. That's key to how they work, which we'll get to. They don't need surface receptors like some other hormones.
Okay, fascinating. So the cortex is handling the slower, more metabolic and electrolyte side of things with these steroids. But then there's the inner medulla. That's a different beast altogether, isn't it? Faster acting.
Completely different. The adrenal medulla is, well, it's essentially a modified sympathetic ganglion, part of your nervous system almost. It's packed with these specialized cells called chromatin cells.
Chromatin cells.
Okay. And these guys pump out the catecholamines. Think adrenaline rush. It's about 80% adrenaline, which is epinephrine, and 20% noradrenaline, or norepinephrine, plus a little dopamine.
Right, the fight or flight hormones. Instant action.
Exactly. Very different from the steroids.
It's incredible. You've got these two distinct regions, cortex and medulla, making totally different, really potent chemicals. How do they know when to release them and how much? What are the body's, internal command centers running this show? And while you're thinking about that, picture this scenario. A patient comes in, they're feeling incredibly tired, their blood pressure is low when they stand up, and they mention almost casually that their skin, especially around old scars and their gums, seems darker. Hold on to that thought. We'll connect the dots.
Okay, great question about the command centers. Let's tackle cortisol first. Its regulation is a beautiful example of an endocrine axis, the hypothalamic pituitary adrenal axis, or HPA axis. Think of it like a 3-level control tower managing stress.
Okay, a control tower. I like that.
Yeah. So level 1, up in the brain, the hypothalamus detects stress or follows a daily rhythm and releases CRH, corticotropin-releasing hormone.
CRH from the hypothalamus, step 1.
Right. Step 2, CRH travels just a short distance to the anterior pituitary gland, telling it to release ACTH, adrenocorticotropic hormone.
ACTH from the pituitary, step 2.
Then, step 3, ACTH travels through the bloodstream down to the adrenal cortex, specifically targeting the zona fasciculata, and tells it to make and release cortisol.
Okay, hypothalamus, CRH is pituitary, DHE, ACTH, adrenal cortex, that's cortisol. Makes sense.
But the really elegant part is the negative feedback loop. As cortisol levels rise in the blood, that cortisol itself signals back to the hypothalamus and the pituitary, telling them, okay, ease up, we've got enough for now. It inhibits further CRH and ACTH release.
So it regulates itself, keeps things in balance.
Exactly. And it's not just stress. There's a natural circadian rhythm, too. Cortisol is typically highest first thing in the morning, helping you wake up, and lowest around midnight. Stressors, physical like injury, chemical like low blood sugar, or emotional, can override that rhythm and push levels up.
Right. And you mentioned something about ACTH precursor, POMC.
Yes, good catch. ACTH is actually cleaved from a larger molecule called POMC, pro-opiomelanocortin. And importantly, another peptide hormone called MMSH, melanocyte-stimulating hormone, also comes from POMC.
MSH, melanocyte-stimulating. Maybe related to skin color.
Precisely. Keep that connection in mind. It becomes clinically very relevant, especially with that patient scenario you mentioned.
Okay, we'll do. So cortisol is released. How does it actually work inside the cells? You said it's lipophilic.
Right. So being fat-soluble, cortisol doesn't need a receptor on the cell surface. It just diffuses right through the cell membrane into the cytoplasm. Inside, it finds and binds to its specific glucocorticoid receptor, GR. This activated cortisol GR complex then travels into the nucleus.
Into the nucleus. So it's affecting DNA.
Exactly. It binds to specific DNA sequences and acts as a transcription factor, either switching genes on or off. This changes the proteins the cell produces.
So that's why its effects are described as like slow but powerful. It's changing gene expression.
Precisely. It's not an instant switch like the catecholamines. It takes time to alter protein synthesis, but the effects are profound and can be long-lasting. This is why chronic stress, or taking steroid medications long-term, can have such widespread effects. It's literally reprogramming cells over time.
Okay, so what are those main effects? We said sugar zone.
Yeah, metabolically, the big picture is that cortisol increases blood glucose. It promotes gluconeogenesis, making new glucose in the liver, and glycogenolysis, breaking down stored glycogen. It also counteracts insulin's effects.
So it's basically making sure the brain has enough fuel, especially during stress.
That's the primary goal, yes. Preserve glucose for the brain. But it also breaks down protein, proteolysis, which can lead to muscle wasting with chronic excess. And it mobilizes fats, lipolysis, but often causes them to be redeposited centrally, hence some of the features we see in Cushing's.
Okay, glucose up, protein breakdown, fat redistribution. What else?
Oh, it's a potent immunosuppressive and anti-inflammatory agent. That's why we use steroid drugs clinically. But it also means excess cortisol makes you more prone to infections. It also impacts the cardiovascular system, increases heart contraction strength, helps maintain vascular tone and blood pressure. It's involved in maintaining plasma volume, influences bone health, chronic excess contributes to osteoporosis, and can affect mood and reproductive function. It really gets everywhere.
Wow. Truly is a multitasker. Okay, so that's cortisol regulated by the HPA axis. Now, what about aldosterone, the salt hormone? Its regulation is different, right? You mentioned angiotensin II.
Yes, very different primary control. While ACTH can have a minor stimulating effect on aldosterone, the main drivers are increases in potassium levels in the blood and, most significantly, angiotensin II. And angiotensin II is the star player in a whole other system, the renin-angiotensin-aldosterone system, or RAAS.
RAAS. Okay, I've heard of that. It's all about blood pressure, isn't it?
Exactly. Think of RAAS as the body's emergency response team for low blood pressure or low fluid volume.
So how does it work? What kicks it off?
Key triggers are things like low blood pressure, low sodium reaching the kidney, or just generally reduced blood flow to the kidneys. When specialized cells in the kidney, the juxtaglomerular cells, sense this, they release an enzyme called renin. That's step 1.
Renin from the kidney. Got you.
So 2, renin floats around and finds a protein made by the liver called angiotensinogen, and it clips off a piece, turning it into angiotensin III.
Angiotensin I. Okay. Still inactive mostly.
Pretty much. Step 3 happens mainly as blood flows through the lungs. There's an enzyme on the surface of lung cells called ACE angiotensin converting enzyme. ACE converts angiotensin I into the active form, angiotensin II.
ACE in the lungs makes angiotensin II.
Right.
And angiotensin II is the powerful one.
Oh, yeah. It's a potent vasoconstrictor, so it squeezes blood vessels, which directly raises blood pressure.
Yeah.
And crucially for our story, it travels to the adrenal cortex, specifically the zona glomerulosa, and strongly stimulates the release of aldosterone.
So RAAS leads to aldosterone release.
That's the main pathway. Increased potassium also directly stimulates aldosterone release, which makes sense because aldosterone helps get rid of potassium.
Okay, so aldosterone is released. Its mission, you said, is sodium in, potassium out, water follows. How does it actually do that at the kidney cell level?
Well, like cortisol, it's a steroid, so it slips into the target cells in the kidney, mainly in the distal tubule and collecting duct. Inside, it binds to its mineralocorticoid receptor, MR. This hormone receptor complex then goes to the nucleus and boosts the production of specific proteins. Key ones are the NAK-ATPase pump, the sodium-potassium pump, and sodium channels called ENAC on the cell surface facing the urine.
So more pumps and channels means more sodium pulled back into the body.
Exactly. More sodium reabsorbed from the urine back into the blood. And because water follows sodium osmotically, water gets reabsorbed too. At the same time, it promotes the secretion of potassium and hydrogen ions into the urine.
So it saves sodium and water, raising blood volume and pressure, and dumps potassium and acid.
Elegant.
Very elegant. A beautiful system for fine-tuning fluid and electrolyte balance and blood pressure.
Which brings us back perfectly to that earlier question, how the body controls these potent chemicals, and that patient case I mentioned, the fatigue, low BP, and the darker skin. Right. So the control systems, the HPA axis for cortisol is like that sophisticated thermostat, constantly adjusting for stress and daily needs via feedback. The RAAS is more like the dedicated plumber and electrician, managing fluid volume and electrolytes to keep the pressure stable. They're distinct but interconnected. And your patient, that constellation of symptoms, fatigue, postural hypotension, low BP on standing, and hyperpigmentation is classic for Addison's disease. Primary adrenal failure.
And the hyperpigmentation is the key.
It's a huge clue for primary failure. Because the adrenal cortex isn't making cortisol, there's no negative feedback to the pituitary. So the pituitary screams for action by pumping out massive amounts of ACTH.
And because ACTH and MSH come from the same precursor, POMC.
Exactly. That excess ACTH, or perhaps other POMC fragments, stimulates the melanocytes, leading to that characteristic darkening of the skin, gums, and creases. You wouldn't see that in secondary adrenal failure, where the pituitary itself isn't making ACTH, no excess ACTH, no hyperpigmentation.
Wow. That makes perfect sense. Understanding the physiology really unlocks the diagnosis there. Okay, so we've covered the cortex hormones and their control. What about the really fast guys from the medulla? Adrenaline and noradrenaline, the catecholamines?
Right, the sprinters of the hormonal world.
How are they made and released so quickly? It feels almost instant sometimes.
It practically is. The synthesis pathway is fairly straightforward, starting with the amino acid tyrosine, going through dopa, then dopamine, then noradrenaline, and finally adrenaline. But the release mechanism is pure speed. The adrenal medulla is directly wired into the sympathetic nervous system. Pre-ganglionic sympathetic nerves synapse right onto those chromaffin cells.
So a nerve signal comes in.
A nerve signal comes in, releases acetylcholine, AC, and that ESIC stimulus makes the chromaffin cells dump their stored catecholamines directly into the bloodstream. It's incredibly fast.
And the effect is that classic fight or flight.
Textbook fight or flight. Heart pounds faster and harder, blood pressure shoots up, blood gets shunted to muscles and the brain, airways open up, pupils dilate, mental alertness peaks, and fuel stores, glucose and fats, are rapidly mobilized. It's all about preparing the body for immediate, intense physical action.
An amazing system for acute emergencies. But like all finely tuned systems, things can go wrong. Disorders of the adrenal glands must present in some pretty dramatic ways.
They certainly can. You basically see problems arising from either too little hormone hyposecretion or too much hormone hypersecretion. And depending on which hormone is affected, you get very distinct clinical syndromes.
Okay, let's link this physiology to the clinic now. This is where it gets really practical for, future doctors. Let's start with too much cortisol Cushing syndrome. What exactly is that, and how is it different from Cushing's disease?
Good distinction to make early. Cushing syndrome is the umbrella term for any condition causing prolonged exposure to excess cortisol. The source doesn't matter initially, it's just too much cortisol overall. Cushing's disease, however, is one specific cause of Cushing's syndrome. It's when the excess cortisol is driven by an ACTH-producing tumor in the pituitary gland.
Okay. Syndrome is the state, disease is a specific pituitary cause. Got it. Are there other causes of the syndrome?
Yes, and there's another handy mnemonic, AAPE.
AAPE. Okay, what does that stand for?
A for adrenal tumor, a tumor in the adrenal cortex itself churning out cortisol independent of ACTH. A for ACTH-producing pituitary tumor, that's Cushing's disease we just mentioned, ACTH dependent. P for paraneoplastic ectopic ACTH. A tumor somewhere else in the body, often small cell lung cancer, starts making ACTH. Also ACTH dependent, some mnemonics use E for ectopic, E for exogenous steroids. This is actually the most common cause overall patients taking glucocorticoid medications like prednisone. This is ACTH independent because the external steroids suppress the pituitary.
AAPE, adrenal, ACTH, pituitary, paraneoplastic ectopic, exogenous. That covers the bases. And the symptoms would directly reflect all those cortisol actions we talked about.
Exactly. You see the metabolic effects, hyperglycemia, maybe even overt diabetes, steroid diabetes, central obesity, fat collecting in the trunk, face, moon face, and upper back, buffalo hump. The protein breakdown leads to muscle wasting, thin, fragile skin that bruises easily, and those characteristic wide purplish stretch marks, or striae.
Right, I've seen pictures of those.
The immunosuppression means increased susceptibility to infections. Bone effects lead to osteoporosis. Cardiovascular effects include hypertension. Cortisol has some weak mineralocorticoid activity. And you can get androgenic effects like excess hair growth, hirsutism, or acne, especially if the cause involves ACTH driving adrenal androgen production too.
So how do you investigate if you suspect Cushing's?
First, you have to confirm cortisol excess. You can do this with tests like measuring cortisol levels late at night. They should be low but are high in Cushing's. Or collecting urine over 24 hours to measure total free cortisol excretion, which will be high. Once you've confirmed that there's too much cortisol, the next step is figuring out why. This is where the dexamethasone suppression tests, DSTs, come in. Dexamethasone is a potent synthetic steroid.
Okay, so you give fake cortisol to see how the body reacts.
Pretty much. A low-dose DST should suppress natural cortisol production in healthy people via negative feedback. If cortisol isn't suppressed, it confirms Cushing's syndrome. Then, a high-dose DST helps distinguish the cause. In Cushing's disease, pituitary tumor, the pituitary is still somewhat responsive to feedback, so the high dose will suppress cortisol production. But if the cause is an adrenal tumor or ectopic ACTH, they won't respond to feedback, and cortisol levels stay high even with the high dose.
Clever. Using physiology to pinpoint the problem. And treatment depends on the cause.
Absolutely. Surgery for pituitary or adrenal tumors, maybe medication, or carefully managing withdrawal if it's exogenous steroids.
Okay, that's excess cortisol. Now, the flip side, adrenal insufficiency. We touched on Addison's disease with the patient example. Can you expand on that?
Sure. Addison's disease is primary adrenal insufficiency. The problem is, in the adrenal glands themselves, the cortex is usually destroyed.
Destroyed? How?
In places like the UK or US, it's most often autoimmune. The body attacks its own adrenal cortex. Worldwide, tuberculosis is still a major cause. Less common causes include infection, hemorrhage, or cancer mets. The key is that the entire cortex is usually affected, so you lose production of all the cortical hormones. Glucocorticoids, cortisol, mineralocorticoids, aldosterone, and adrenal androgens.
All three. So the symptoms reflect all those losses.
Exactly. Lack of cortisol leads to fatigue, lethargy, weight loss, anorexia, low blood sugar. Lack of aldosterone causes salt wasting, low blood pressure, especially postural hypotension, and high potassium levels. Lack of androgens might cause loss of body hair in women.
And the hyperpigmentation we discussed.
And the hyperpigmentation, due to that high ACTH and primary failure. Biochemically, you classically see low sodium, high potassium, and low glucose.
How do you confirm Addison's?
The definitive test is the short synacthin test, also called the ACTH stimulation test. You measure baseline cortisol, give an injection of synthetic ACTH, sandactin, and measure cortisol again after 30-60 minutes.
And what should happen?
In a healthy person, the ACTH shot should make the adrenals pump out cortisol, so the level doubles or rises significantly. In Addison's, the adrenals are damaged and can't respond, so the cortisol level stays low, showing minimal or no rise.
That makes sense. It tests the gland's ability to respond. And you mentioned Addisonian crisis.
Yes, that's a life-threatening emergency. It's profound circulatory collapse due to lack of cortisol and aldosterone, severe hypotension, shock, dehydration, hypoglycemia, electrolyte chaos, low sodium, high potassium. Needs immediate IV fluids and high-dose hydrocortisone, which has both glucocorticoid and mineralocorticoid effects.
Critical to recognize it. And just quickly, how does this differ from secondary adrenal failure?
In secondary failure, the problem is upstream. The pituitary isn't making enough ACTH. So the adrenals could work They just aren't getting the signal for cortisol production. Aldosterone production, mainly controlled by RAAS, is usually preserved. And crucially, because ACTH levels are low, you do not see hyperpigmentation.
Okay, that distinction is really important. Primary means gland failure, high ACTH, hyperpigmentation, loss of all cortical hormones. Secondary means pituitary failure, low ACTH, no hyperpigmentation. Aldosterone, usually okay.
You've got it.
Great. Now, another too much condition, but this time focusing on aldosterone. Conn syndrome.
Right, Conn syndrome is primary hyperaldosteronism. The adrenal gland itself, specifically the zona glomerulosa, is overproducing aldosterone independent of the RAAS system. In fact, renin levels will usually be suppressed due to the high aldosterone.
What causes that overproduction?
Most commonly, it's either bilateral adrenal hyperplasia, both glands are just generally overactive, that accounts for about 60% of cases. Or in about 30%, it's a single benign tumor called an aldosterone-producing adenoma, APA.
And the symptoms directly follow from too much aldosterone.
Exactly. Think salt effects amplified. Too much sodium and water retention leads to hypertension, often resistant to standard treatments. Too much potassium secretion leads to hypokalemia, low potassium. And too much hydrogen ion secretion leads to metabolic alkalosis.
So high blood pressure, low potassium, maybe muscle weakness or cramps from the low potassium.
Precisely. The initial screening test looks at the ratio of aldosterone to renin in the blood. ARR. In cons, aldosterone will be high and renin will be low, so the ratio is high. Then imaging like CT or MRI helps find an adenoma or see if the glands look hyperplastic.
And treatment.
If it's an adenoma, surgery to remove that adrenal gland, adrenalectomy, can be curative. If it's bilateral hyperplasia, surgery isn't usually the answer, so you use medications that block the aldosterone receptor, like spironolactone or epinephrine.
Okay, it makes sense. Now, one last major disorder, this one originating from the medulla. The Phaeochromocytoma. Sounds dramatic.
It can be. A phaeochromocytoma, or Pheo for short, is a tumor of the chromaffin cells in the adrenal medulla.
So it's pumping out massive amounts.
There are catecholamines, adrenaline and noradrenaline, uncontrollably.
Fight or flight gone wild.
That's a good way to put it. It's a rare cause of high blood pressure, but important because it's often curable if found and can be fatal if missed, especially during surgery or childbirth if unprepared.
Is there a way to remember its features?
There's the classic, though not entirely accurate anymore, rule of tens. Roughly 10% are extraadrenals, arising from sympathetic ganglia elsewhere. 10% are malignant, 10% are bilateral, in both adrenals, often in genetic syndromes.
Okay, rule of tens and the symptoms. Are they constant?
Often episodic, coming in attacks or spells. Think of the 5 Ps. Pressure, sudden high blood pressure, pain, headache, perspiration, sweating, palpitations, racing heart. And power, paleness. Basically, sudden, severe sympathetic overdrive.
5 Ps. Pressure, pain, perspiration, pallor. Got it. How do you test for it? Catecholamines in the blood.
Measuring blood catecholamines can be tricky because the release is episodic. A better test is usually measuring their breakdown products, metanephrines, in a 24-hour urine collection or sometimes in plasma. These levels are more stable and reflect total production over time.
Metanephrines. Okay. And treatment. Surgery again?
Definitive treatment is surgical removal of the tumor. But, and this is absolutely critical, you must medically stabilize the patient before surgery. You need to block the effects of all those catecholamines first.
Block them.
Crucially, you start with alpha blockers first to control the blood pressure and prevent severe vasoconstriction. Only after achieving good alpha blockade do you add beta blockers to control the heart rate. If you give beta blockers first, you risk unopposed alpha stimulation, which can cause a catastrophic hypertensive crisis. Alpha, then beta, always.
Alpha, then beta. Got it. Critical point. Wow. Okay, we've covered a lot of ground, so let's try to synthesize this. For you, our listener, heading into your medical career, what are the big takeaways here?
Well, clearly, the adrenal glands are just fundamental to how the body handles stress, manages metabolism, and keeps blood pressure stable. That seems obvious. But I think the deeper point is seeing how understanding the underlying physiology, the HPA axis, RAAS, catecholamine release, directly unlocks your ability to understand why patients present the way they do. It's not just memorizing symptoms, it's connecting them back to the mechanism. And maybe also that point about exogenous steroids, because they're used so often.
Absolutely. Realizing that giving someone prednisone is essentially creating iatrogenic Cushing syndrome, and that it suppresses their own HPA axis is vital. It explains why you see Cushing-Goya side effects and why you absolutely cannot stop high-dose steroids abruptly. You risk triggering secondary adrenal insufficiency and Addisonian-like crisis. patient education and careful tapering are paramount.
Right. Makes total sense. And thinking about the diagnostic tests we discussed, the dexamethasone suppression test, the synacthin tests, don't just see them as steps in an algorithm, appreciate them as really elegant physiological experiments. You're actively probing these feedback loops and hormone pathways to see where the break is. So always be asking yourself those questions. Is this primary a problem in the gland itself, or secondary a problem upstream, like the pituitary? And which specific hormones' actions, or lack thereof, explain the pattern of symptoms I'm seeing? That kind of thinking is what makes a good diagnostician.
Excellent points. Physiology isn't just background, it's the toolkit for clinical reasoning. Well, that brings us towards the end of this deep dive into the adrenal glands. We've mapped the territory, unpacked the salt, sugar, sex hormones of the cortex, felt the rush of the medulla's catecholamines, and explored the consequences when these finely tuned systems are disrupted.
It's been a comprehensive tour. And maybe, as a final thought to leave you with, consider the body's resilience. Even when facing chronic stress or these endocrine disorders, the body desperately tries to compensate and maintain some semblance of balance, homeostasis. What other fascinating, maybe subtle adaptations or compensatory mechanisms might be going on under the surface in these chronic conditions, beyond the main pathways we've discussed? What backup systems does the body try to employ before things really fall apart? It just highlights how integrated and, frankly, amazing human physiology is. Keep exploring that as you see these concepts pop up again in pharmacology, pathology, and on the wards.
A great thought to end on. The body's constant struggle for balance. Thank you for joining us on this deep dive. Keep learning, keep questioning, and keep diving deep.